Thank you. So since I was a doctor in my first postgraduate year and throughout my emergency medicine training, and even after the end of my training as a consultant, I've been required to show evidence of reflection in order to progress in my career, and I'm sure the same is true of most of you. And that's an interesting thing for me as a medical educator. I've been reflecting on reflection for quite some time, because that's the kind of wild stuff we do. And there's a problem here, as I see it, because there's a distortion. If you tell somebody they have to reflect, it doesn't usually work. How do you know they've really done it? It's like when you want somebody to forgive somebody. How do you know they've really done it? How do you know somebody has really fallen in love? This is a problem for us. It's a paradox, because having insight into the things we do is key to us being perpetual learners, lifelong learners, and that's what we need to be if we want to be the best for our patients. So it's given reflection a bit of a bad name, and I'd like us to think about that and maybe reframe it a little bit and think about reflection a bit differently. So what is reflection? Well, there's a really nice definition that I like, and it's this by John Sanders. It's a metacognitive process that creates a greater understanding of both the self and the situation, so that future actions can be informed by this understanding. And I like this because it gets at the head part, and then the heart part, and then the bringing it out with your hands. What are we going to do with this information? And I think this definition really draws out for us that reflection is one of the sharpest tools that we have in improving our care. Understanding that how and why of the decisions we make, of the words that we use, and the actions that we undertake can help us to make better choices and deliver better patient care. But there are some problems, things we've alluded to already. Jenny Rudolph said earlier, we want learning to happen from errors, we don't want blame. And Jenny Vaughan brought up some very prominent cases in which reflection has been seen to be a problem. The idea that us trying to learn from those mistakes can be used against us is terrifying, but the law is very clear. If we write something about a case in which an error has occurred and we take the blame for that error, that can be subpoenaed and it can be used in court. And understandably, we are concerned and we're scared of reflecting in that context. The second challenge is that, to an extent, medical educators like me have done us a disservice. We're so keen for people to reflect that we've made it into this tick box exercise, and we've taken some of the power out of it. And the third problem is something that Simon alluded to. Just like when we look in the mirror, when we're reflecting, what is seen and said and discussed and thought is not the whole truth, because we're not capable of that. It's going to be changed in some ways that we may or may not be able to appreciate. And some of that is because of the subconscious biases that we carry. And some of it is a self-protective mechanism, because there are things that we need to believe about ourselves. So let's think about the context in which we undertake reflection. And I think it generally happens in two very different sets of circumstances. The first is planned or proactive reflection, and I'm talking about in the context of kind of learning events where there's an observation. So what happens is there's usually a conversation that happens beforehand, an objective or a pre-brief like you might use in simulation. Then there's the learning event which is observed. There's a debrief, and then the bit in which the heart comes into it and the change is made, that's the point at which reflection is happening, and that's the key step. And there is some crossover between feedback and debrief and reflection, and there has to be when it's done collaboratively with other people, which is what we're talking about in that sort of situation. And that means that there has to be a need for psychological safety if we want people to actually make changes. And that's why some of the most powerful, effective changes that we see as a result of reflection happen in long-term, longitudinal mentor relationships. The second set of circumstances in which we reflect are the unplanned or reactive reflections. So these are the things that happen after those big cases, the bad stuff, the cardiac arrests, the big traumas, when things have gone wrong. And the difference here is that there is no pre-brief. No one knew this was going to happen. Nobody set down what we were going to talk about, what we were going to learn from this in advance. So it's all over the place. But this can be so powerful and so meaningful. And what that means for us as educators is that need for psychological safety is even higher. If we want to get the most learning out of this, we need to go really deep, and that has to be safe. And this is one of the mistakes that we make. We think that we can and have to reflect on the really big stuff. But if we get practiced at it, there's actually learning in almost everything we do. We can reflect on absolutely anything and absolutely everything. We can extract golden nuggets of learning from the big and the small, from the extraordinary and the mundane, if we just practice it. So how do we practice it? Well, there's lots of models out there that can help us. Kolb's reflective cycle is one of the most well-known. But essentially, they all boil down to this same structure. Understanding the facts of what happened, then breaking down the reasoning about why things happen that way, and then making some future planning. What is it that we want to do differently to have a different outcome? And crucially, what is it we want to do again because it worked so well? And when we approach reflection, we need to do it for ourselves with curiosity, not vanity. We have to have self-confidence and self-respect and humility to be able to be honest about the times when we've made mistakes. And that's really hard, but it does get easy with practice, and when we do it with trusted colleagues. And the flip side of that is, in the grip of imposter syndrome, we sometimes need other people to give us permission to take credit for the things that we've done well, because that doesn't come all that naturally to us. So how can we wrap this all up? Well, when we have to reflect on the really difficult stuff, those cases where things have gone really badly, we need to look out for each other. And Jenny Vaughan alluded to this idea of safe reflection. We need to help each other to make sure that what we're recording in cases that have gone badly is not incriminating. And we need to take a collective responsibility for that. And then on a more informal, natural day-to-day basis, we can work alongside our colleagues and our trainees and our bosses. And we can role model that attitude of reflection and help each other to learn. And we can teach our trainees how to record their reflections and their learning in an anonymous way that doesn't relate to patient cases and keep them safe that way. And lastly, for us, for ourselves, it's really important that we get into the habit of reflection because it helps us to see more clearly how we're working in our careers. It gives us an idea of where we are and where we should be going to. And we can see it as a sort of mindfulness activity, part of our self-care. There's good evidence that when we use mindfulness as part of self-care, that it improves not just the clinical care we give, but the lives that we lead. It has a positive effect on who we are as people, just like when we really do fall in love. Thank you.